This is Brian Kavanaugh. Welcome to the inaugural Maryann and Robert Bruno Lecture in Radiation Oncology. Our honored speaker is Dr. Robert Timmerman from UT Southwestern. The title of his talk is PULSAR, the Adaptation of SAbR toward Personalized Medicine. I hope you enjoy it. Dr. Timmerman hardly needs any introduction. He's a household name in the field. But for the benefit of those who might have just entered the field, our youngest residents perhaps, I thought I might just give a little bit of context.
I would venture to say that at this moment, if you verify this on his Google Scholar page with his 28,000 citations, that I think Timmerman is the most influential radiation oncologist of his generation, just to say my generation, okay? And I know that H indices and all these other metrics are, arguably imperfect metrics, but they're still there and still means a lot that 2,500 people have bothered to cite this particular paper, which I think is, of course, at the top of his list of citations. It is the RTOG-0236 study on medically inoperable non-small cell lung cancer. This paper is epochal in the sense that it is a era-defining moment. And I think it's because not just that result, not just that one study, but the lead up to it and the transition it represents in, I think, mindset within the field. This, of course, did not happen overnight. I wanted to sort of convey to those who were not in practice 20 years ago when this was happening, in the previous 10 years when the buildup was going to it. What you have to appreciate is that Bob was really swimming upstream against the current of non-believers, skeptics, and traditionalists who did not think that this type of approach, this idea of using stereotactic treatment, high-dose refraction, et cetera, was a good thing. They thought it was blatantly dangerous. They thought it was evil. They thought it was corrupt. They had visions of the dystopian hellscape that would follow in this field if this kind of thing caught on. Well, obviously, it was proven wrong, but the only reason that got through, the only reason we reached that epochal moment of this publication, which has then opened the floodgates to a lot of other things, and just about everything we do in the field now, is because of Bob's perseverance, his discipline, his stick-to-itiveness, his ability to work his way around the skeptics and have patience with them and yet stick to his principles. And so I just have to impress upon those new to the field that the work behind that, to get to that point, that opened the pathway to most everything we do nowadays, or so many things we do nowadays, was not an easy road. And we, the field, have a lot to appreciate and be grateful for Bob's contribution. So without further ado, we introduce Bob Timmerman, Professor and Chair of Radiation Oncology at the University of Southwestern.
So welcome and thank you, Bob.
Just yesterday, as I was going to the airport, I turned around. This is my ranch, so it's kind of cliche, but I have a ranch in Texas, raise cattle. And I looked back, and Texas has been a scorcher all summer, horrible, to the point where I was afraid I would have to sell cattle because there was just not enough feed. But then we got 5.5 inches of rain last week, and it rained up like that in just one day. The clouds are still lingering, but I thought it was pretty nice looking, so I'd share it with you. So what's the potential of radiotherapy? We're currently the second most commonly used cancer and also the second most curative cancer, both of them behind surgery. And we're particularly more curative than drug therapy, but we're still second. And in terms of how would we increase the impact of radiotherapy, ideally we should be just as curative as surgery, because any tumor can be eradicated by radiation. And that sounds a bit conceited, but we could give enough dose to kill any tumor, and yet we would then potentially threaten that time-honored tolerance of radiotherapy. That is, we can treat people that surgeons can't treat, people that could never get off a ventilator after an operation, things like that. And SAbR has sort of been the poster child of hypofractionation. We use technology to create SAbR. SAbR was totally enabled by technology, and we went from 30 treatments to 3. But Brian, I think we did SAbR wrong. And so today I want to talk about how maybe we could errors of the past. So SAbR did this. It went from, I was trained on the left, that is a treatment field that went through and through. It was called a postage stamp. And so the lung in front of it, the ribs, everything got the same dose as the tumor. And then SAbR allowed us to do that little field. Any fool can do a little target and miss, but we didn't miss. We used technology not to miss. And so it was sort of enabled by image guidance that looked at the anatomical form or the anatomy in a very careful way. But these are still class solutions, and class solutions, especially surgery and radiotherapy, are one-size-fits-all therapies. Once we decide what the diagnosis is, we give the standard treatment. We start it and we finish it. And SAbR is even guilty of that. We give different doses for different diseases, but that's what we give. And every patient with that diagnosis gets it. The trouble with that, after 3 to 6 months, when we look and see if it worked or not, we've often burned a bridge. That is, we've treated to tolerance, and we may not be able to correct things if things are not going well. Or maybe we over-treated. I asked Albert Kuhn, I was visiting MD Anderson the other day. I said, Albert, among the patients that we cure with radiation, how many do you think were over-treated? He thought a while, and he came up with the exact same number that I made up, which is, I bet 50%. I bet half of the patients that we cure with radiation for cancer didn't need as much dose as they got, didn't need as many treatments as they got. And that's a shame, because that's toxicity for no benefit. But we don't know right now when that trigger happens. And so here we have 2 sinus tumors. The one in the top frames had a really nice response to radiation. And the one on the bottom frame with the maxilla on the left even grew after radiation. So the question is, did the first patient get over-treated? And obviously the second patient got under-treated because they're progressing after therapy. So we're sort of at the crossroads as a field. We've been a technology-oriented field. That worked well for me because I have a technology background. We have all those things that are sort of tech-savvy. Medical oncology, in contrast, is a biology-oriented field. They're driven by biomarkers, and they come across as being more modern and progressive. So we work by brute force. They are more elegant. And the question is, should we transition ourselves as a field to be more biology-oriented, enabled by technology, but not driven by it? So the pharmaceutical approach to curing cancer is to identify a biological pathway, something that allows the tumor to evade the immune system, something that allows the tumor to metabolize, whatever. You identify that particular mechanism, and then you sabotage it with a drug. And so you end up hyper-selecting patients, because your ALK drugs only work for ALK-positive patients. So you find out who's ALK-positive. Sadly, though, it's only 5%, and that's the downfall of this approach, is that often the biomarker is very limited, and therefore it's not used on a broad scale. And that's in contrast to our approach, which is to use local therapy to intensify the treatment effect, sort of get over the resistance of the tumor. In the case of SAbR, that was enabled by image guidance. But the better approach is to use technologies not to guide the beams so carefully or so intently, but to define the patient's biology. Use technology to decide how a specific patient's cancer is behaving, and then figure out how to change the therapy, hopefully before you're all out of ammo, to one that actually cures the tumor with the least amount of therapy. So in other words, a unique therapy for a unique patient. So now we just bought all these machines. They're expensive. They're called adaptive machines, and so they can image on the fly with pretty nice imaging. They can replan quickly. And so ideally we'll do this treatment that's adaptive or responding to change. The Achilles heel of that is that it's all based on form, that is anatomical imaging, so position and shape. These are all anatomical features. And so you start out with a patient with this right upper lobe tumor. You're going to give them a hypofractionated course of radiation. 2-3 weeks into the treatment, it looks like that. I don't know about you, but to me, it doesn't look much different. So what's the change that we're going to adapt to? Then you finish the therapy. Now, 100 days later, you repeat a PET scan and things are going well. This is telling you that both the tumor has shrunk and that the PET signal has decreased. But if you really wanted to adapt, shouldn't you have waited for the change to occur? We're already done with therapy when we found out that information. The big change occurred after the therapy was completed. So with daily uninterrupted courses of radiotherapy, including SAbR, there's not a whole lot of change. And if there's no change, there's no meaningful adaptation. So I'm going to say 2 sensible things, because I've been accused a lot in my career of saying unsensible things. But I think these are sensible things. The bigger the change, potentially the more meaningful the adaptation. I hope everybody agrees. And second, bigger changes may take longer to occur, especially in biology. In physics, we're talking milliseconds and nanoseconds. In biology, we're talking weeks to months for meaningful changes to occur. So the field of radiation oncology treats without interruption. In fact, you hopefully know that you should get your head and neck and your cervix cancer course over with as soon as you can without treatment interruptions. Otherwise, their outcomes are going to be worse. We've done that not just with conventional radiotherapy like that, but we've also done it with SAbR. Every day or every other day or every third day. It's still getting over with pretty quickly. And we even market that as a benefit of the treatment. So should we rethink this in the adaptive era? So we introduced PULSAR. PULSAR is a new radiotherapy which totally abandons fractionations. Boy, everybody's going to be thrilled about this, aren't they? I think 100 years of fractionation is enough. Let's do something different, because it was in the 1920s that fractionation came to be. Why did it come to be? Because technology sucked in 1920. And you ended up giving way more dose to normal tissues and tumors. The only option was to fractionate. But we love it as a field. And by the way, we're reimbursed based on it. So if you're not going to fractionate, if you're going to give pulses instead, and these are standalone treatments, as if you met a new patient for the first time every time you see them, then you're going to have to give more than 2 gray. You're going to have to give a big enough dose. So I'm talking 8 gray, 20 gray, something such that you don't have to worry about tumor progression after that pulse, at least for a while, at least weeks to months. And you can get more than 1 pulse, but they have to be separated. Now it's going to be a completely different paradigm integrating with systemic therapy too, because now we're going to be sort of like drugs are given in cycles instead of daily treatments. So the basic requirements for PULSAR, and I think for better adaptive therapy in general, is that we need feedback about what's going on, not to the shape of the tumor, not to the form or the shape, but to the biology of the tumor and the patient. How are they tolerating it? So that we can use that information. And then we need to wait. We need meaningful time to elapse so that that biology can occur. And so far, you guys have adaptive therapy machines, right? Not yet, but when you get it, first you'll be excited about it, then you'll hate it. But the point is, you adapt to position and shape. Position means, is the patient rotated on the table compared to where they were in the simulation? And the shape is 2 things. Is the normal tissue different? So is the bladder fuller than it was or more empty than it was at the simulation? Or is the tumor shrunk? And of course, the holy grail is the tumor shrinking, right? Those are all anatomical form. Now, I flunked out of architecture before I went to medicine, but I learned one thing at least, and that is form follows function. It's an architectural rule that basically says the way a building looks is mostly related to what happens in the building. And so you have to first think about how people live in that space before you decide what the aesthetics of that space should be. Otherwise, it will be a failure, because function is more important than form. Function is more important than aesthetics. And so the B-1 bomber looks the way it does, which is so cool. Not because we wanted it to look cool, it's because that's the stealthiest way for something to fly through the air. And so the function of it prevails at defining its form. And it's true in anatomy too. So the form following function is true in medicine as well. So the eyeball is a cool structure, but it's designed the way it is so that light can go through, be focused on the retina, electrical signals can be converted, go through a wire back to the back of the brain so that you can reconstitute an image. So anatomy, that cool anatomy, still totally depends on what that eyeball does in terms of its function. So radiotherapy as a field, we followed form and function at different times in our history, but mostly form. That is, what do we aim at, what do we miss? And so since the 2D and 3D eras, we've been guided by form. My whole career has been based on this. Very sophisticated tracking systems, guidance systems, delivery systems. But biology is more about function. That is, what's happening to those cells biologically. Are they proliferating or not? Are they hypoxic or not? And currently, the adaptive process, as it's being proposed by every paper you read about adaptive therapy, is adapting to position and shape. That's all form. That's not a single bit of function. And I think we will be disappointed in the end with the results of that if that's the path we continue to follow primarily. So how can it be done? We need a change. We need a delta. In mathematics, change is always defined by delta, right? And so, of course, we have adapting to shape, and this is what we want. So before the plan prior to Pulse 2 was that big, and prior to Pulse 3, a month later, it was a lot smaller. So PULSAR is really good at making tumors shrink, believe me. I've never seen tumors shrink so fast, but that's not the key to this. The tumor shrinking is not the key, but there's so much more to consider. And like I say, we've imaged form so strongly to where we can even, there's two little tumors inside that vertebra, they're both sclerotic. I can give higher dose to those tumors. I can use the multi-leaves to paint it. I can hit it with high accuracy, but it's all based on form. The target, the sclerosis is the target, and the beams are guided based on form. Yet we should not forget that form follows function. Function is more important than form. This is a patient who has kidney cancer, and he gets workup that shows he has no metastatic disease. And so, you know, at that point, then we wouldn't do anything. But if we knew he only had one tumor in his body, he has a cure rate. He has a cure rate of about 20% with oligometastasis fewer than 3 tumors. We do a PDL1 PET scan instead of a more anatomical image, and it shows a little spot in the distal femur on the left side, which in fact is a tumor in his femur. So now instead of following that patient with no chance of cure, we treat that tumor and afford him at least a 20% chance of cure that he otherwise wouldn't have had, which is all defined on function, not form. And here's some, I treat brain tumors, and we commonly use the T1 post-contrast and the flare to define our targets. I assume you do too. And these are cool images. You've got tons of anatomical detail. We love them. We're good at looking at them. But in this particular patient, it starts out with an enhancing tumor and a flare signal. So you probably have 2 different volumes. After 3 weeks, it's looking maybe even a little bigger. But after 10 weeks, it looks like things are going well. It looks like some of that T1 with contrast imaging is starting to regress. But there's another imaging called arterial spin labeling. It's not pretty to look at. I skim over these usually when I look at radiology PAC systems. But look what happened with the arterial spin labeling. It started out defining that same target just as well as the T1 with contrast did, but by 3 weeks, it already showed that there was a response. In other words, an early signal of response. So in the end, I would argue that the arterial spin labeling is far more useful, a functional image, than the anatomical image that we're so used to. So PULSAR needs these functional features because function is more important and it relates to biology, all those things that we learn about in radiobiology. And these features may take a long period of time to measure to detect a meaningful delta. We should store those to retrieve them, analyze them, determine what correlates to that type of a delta, like that arterial spin labeling decreasing as an early signal, so that we could personalize the therapy with a new directive, a different way to treat that patient, midstream, not at the end, not as salvage, but midstream. So PULSAR has 3 attractions. Number 1, split course treatments are less toxic. Brian knows this. All the split course treatments that we did in 2 gray fractions were less toxic, every one of them. So they would give a couple of weeks of 2 gray per fraction treatment, they'd give a couple of weeks break, and they'd follow that with finishing the treatment with more 2 gray per fraction treatments. And every one of those randomized trials, and there were many, were less toxic. So putting a break in the middle of the therapy is less toxic. What was the problem? The tumors liked it better too. So the tumors grew, and in the end, it was a wash. You got more tumor recurrence, and so you had to up the dose to overcome that. Second, PULSAR, the long intervals will facilitate what I call meaningful adaptation. That is, respond to a big change rather than a little change. And ideally, that would be driven by biomarkers, similar to the way the ALK positive patients get an ALK drug. Then finally, and this one was kind of surprising, long intervals between treatments facilitates adaptive immunity. And this has to do with vaccinations and things like that, and we'll talk about that more. This is another view of my ranch. We raise cattle, but we also have a vineyard. And this was this year from my neighbor's house across the way. You can sort of see along these paths. Turns out growing grapes is a lot of work. And when you sell them, by the way, we get tons of grapes from this vineyard, but when you sell them, you get just a little bit of money. So I think the point is vineyards are for looks. They're like a longhorn. The only thing good about a longhorn is they look really good on the lawn. So let's go through those three benefits of PULSAR just quickly. So first of all, split course treatments are less toxic. In other words, fractions are more toxic than pulses are. This is a randomized trial from Canada where they compared QOD every other day SAbR radiation for prostate cancer to every week SAbR treatment for prostate cancer. We give 8 gray times 5, and the endpoints were long, late toxicity. The early toxicity was definitely better. It was published, after some follow-up. And on the weekly treatment, the acute toxicity was significantly less toxic. So it proved my point. PULSAR is less toxic. They didn't call this PULSAR, by the way, but they were trying to reduce toxicity. Now the late toxicity was no different, so it ended up being a negative trial. But I would argue they just didn't wait long enough. They should have waited 2 weeks between the pulses instead of 1 week between the pulses. But most importantly, and different from 2 gray fractions, PSA control was no different between the arms. In other words, there was no penalty to adding that extra time between the pulses. And this is an experience from Cleveland Clinic, not randomized, but they were disappointed with their treatments of brain metastasis, where you would give certain doses for a certain size of tumor, and especially for the bigger tumors, they were disappointed with their historical control rates. And so they decided to give 2 treatments, 15 gray, a month apart, and with their radiosurgery systems, I think is the Gamma knife. Their historical experience was poor control with a high risk of radionecrosis, because big tumors are more likely to get radionecrosis. And the results of doing this were improving the control rates. Now it's up to almost 90%, and a much less risk of toxicity. So they do this now. 40% of their patients get this PULSAR-like schedule, 15 gray a month apart. Now, the second thing that I argued PULSAR is better at was that long intervals between pulses facilitates adaptation. And the way I'm getting at this is that, let's say we start out with a tumor, a cartoon tumor, that looks like that. And then we treat it with a pulse. Let's say we give it 10 gray, and it gets bigger. That is important information. That tumor must have a fair amount of resistance. And so now we're nervous up the pulse dose. And so instead of 10, we might give 15 with the second pulse. We might add a sensitizer because we need to get a little help. Now it starts to behave itself, starts to shrink again. So we keep going, and things are going better with a new strategy that we enacted after the first pulse. We finish, but we're nervous because that happened. So we add a drug because we think there's a high risk of recurrence or metastasis. Contrast that to if that tumor had shrunk in the first place. That's important information. And so maybe we decrease the pulse dose. Maybe we're on the road to overtreatment. So now it continues to shrink. After 4 pulses, it's so small that we decide to quit. That's enough. We don't need to give 5 pulses to that particular patient. And that was all based on shape. So it's form. I just argued we should be basing it on function. But we could have looked at functional things, both biological, molecular, and organ system things related to function, such as the tumor itself. Is it PD-L1 positive? Is it PD-L1 negative? Does it got a high mitotic index? We could look at the tumor microenvironment. What kind of cells are already in there trying to fight the tumor or not? Is it hypoxic? Things like that. And then the hosts themselves. That is, are they tolerating it well? Are they losing weight? What are their circulating tumor cells in their body declining or increasing? In other words, interrogate that patient longitudinally with time while the treatment is still going on, so that in fact, maybe even repeat a biopsy. We've been loath to biopsy people, right? Because it never changed what we did and it always had a risk. But maybe now is the time to start doing that if it really made a difference. And the question is, should the therapy be continued as is, intensified or de-intensified? In other words, a directive. And that directive would be based on all that stuff that I just mentioned. And it's really complicated. So it's sort of begging for a machine learning approach to do that kind of an approach. And then finally, and this was surprising, long intervals between pulses fosters adaptive immunity. And so Charles Drake gave me this slide that he talked about what does radiation do in terms of current thinking as to how it might facilitate an immune reaction. And the idea is that it vaccinates. That is, that it takes hidden tumor-specific antigens and exposes them to the immune system so that they can be recognized and mount immune reaction. The way that works is that we take the DNA from the specific DNA from the nucleus, put it in the cytosol by an explosion, and then the CGAS sting pathway maybe gets activated. Dendritic cells come in, take that antigen, they leave the tumor. They have to leave the tumor for this to happen. They go to the lymph node chain that is in the region of the tumor, where they hopefully meet a T cell that has that same antigen. That T cell then proliferates and comes back either to the tumor or to elsewhere, maybe where there's a metastasis, and fights the tumor wherever it lives. So if that's true, we're effectively doing an in situ vaccination. And the process that I just described does not happen in milliseconds. The process that I just described happens in weeks to months. So if radiation is a vaccine, how do we give vaccines? Did you get your COVID vaccine every day, every other day? No, we give initial inoculations. We follow that weeks or months later by booster shots. And so here's the TPT childhood vaccination schedule, and you'll see it's every several months. So if we really think that radiation is a vaccine, why are we giving it not like a vaccine? I assume the people that give vaccines did that for a reason. I don't know what the reason is, but I assume they did. But PULSAR is more like the schedule of a vaccine. So that's all talk though, right? So we did some preclinical work in mice, and what we did was we implanted a tumor, and then we gave it 2 doses of radiation. And the 2 doses of radiation were separated by 15 minutes, which meant 1 dose of radiation, or different points, half day, a day, 4 days, 10 days, 20 days. So the radiation now is separated by a period of time, short periods of time, long periods of time. And then on top of that, we added an immunotherapy drug, in this case, a PD-L1 inhibitor, a checkpoint inhibitor, to assess the effect of both the radiation and the drug. And what we saw was just amazing. So in this case, what you're seeing is that we also give a vehicle. It's just the immunotherapy without the active site on it. And this particular tumor that I'm showing is Lewis lung. It's a cold tumor. It doesn't respond to immunotherapy. And so the first panel of the growth characteristics show that there was no benefit to the immunotherapy in this particular animal model. If you give radiation, the radiation has effect. So the radiation slows down the growth of the tumor. And if it's given a day apart, this is this curve, but if you add the immunotherapy on top of that, the immunotherapy still has no effect. If you give the radiation 4 days apart, still the drug has no effect. But if you give the radiation 10 days apart, interestingly, all of a sudden the drug starts to work. So a drug that does not work, works, but only if you give the radiation a certain way. Isn't that just fascinating? So we basically, by giving radiation a certain way, allowed this animal to have a benefit from a drug that otherwise would have no benefit. And so you question why, and that's just an observation that I just showed you. It's not a mechanism. This is some work from Mike Story, where he just looked at, after a big dose of radiation, what comes into the tumor environment at different times. And you can see that different cells that are part of the immune system come in at different times. And they might be bimodal, but the point is that these cells are coming in at different times. So different cells could be explaining what I just showed you. And what we hypothesized is that if you give a day 0 radiation treatment, then that might vaccinate the patient. So now there's triggering of the T cell response in the lymph nodes, stuff like that. Now, if you give the radiation from days 1 to 4, what we're hypothesizing is that you might be killing the very cells that you were trying to recruit. That is, you might be killing T cells that enter, you might be killing dendritic cells that are leaving. I don't know which, we're learning that right now. But this is a reasonable hypothesis. Whereas if you give the radiation 10 to 30 days later, it just acts like a booster shot, another vaccination. Now here's some clinical examples of PULSAR. So the first benefit of PULSAR is to reduce toxicity. So in the middle, this is a patient, actually a physician, who has a never smoker lung cancer, adenocarcinoma, and it has this property where it's making tons of sputum. So he can't practice medicine because he's coughing constantly. It's called bronchorrhea, and he's miserable. And so sort of as a palliation, because he's got widely metastatic lung cancer, I treat the biggest conglomerate of the patient's tumor, and it would be pretty toxic to treat that big of a volume. And so I decided to do PULSAR. So I give 10 gray, and I treat this volume, and it's big. And it makes me a little nervous to treat that big of a volume. I would have really been nervous to give it 10 gray the next day, but I did. I waited, and so a month later he comes back, and this is the ethos system. It's one of the adaptive systems, and look what had happened. There was this miraculous response. If I would give that same plan again, I would just be treating normal lung. So the machine is able to readapt it to treat the smaller volume. So that's adaptive therapy, the way it's defined. But the cool thing was the patient's back to work, and he's a physician, so he's really pragmatic. And I give him the second pulse with this one, and he's feeling so good. He says, "I don't want any more," and so he's done. So that's the end of his course. No toxicity at all. This is a patient with mesothelioma who's recurring along the resection margin. So when you do an external pleural lumenectomy, wherever the diaphragm was, wherever the pleural was, you could have potential recurrences, and they did. So he ends up with 4 tumors, and I've circled them here, all along the resection margin, including a fairly large mediastinal node. And at this point, there's no treatment options. He's already had, and he went to MD Anderson, got the big radiation that they give there for mesotheliomas, and then the doctor who was at MD Anderson actually treated a MET before they were sent to me. Insurance rejected any treatment with radiation. We did it anyway. And so we planned to give up to 5 pulses. And so this is a very risky radiation situation, right? They've already had, what do they give for mesothelioma? 60 gray? Something like that. And so we plan to give up to 5 pulses, but they're going to be 2 weeks apart. After 2 pulses, the periaortic node disappears. My partner's covering me. He says, if I can't see it, I'm not going to treat it. So he stops. I was kind of mad about that when I heard about it, but then I got thinking, he's sort of doing what I've been preaching. He thought that there was a good response. He stopped. So I stopped too. And then after 4 pulses, 2 more of the tumors disappeared to the point that only the mediastinal tumor got all 5 pulses. And here's what happens. He's 18 months out, and he's NED in all sites. So every tumor got a different dose, and yet all were controlled with a different dose. And that makes sense. Tumors are not homogeneous. Tumors will have variable radiosensitivity in the same patient. That makes sense. Because what we currently do doesn't make sense. That is, for brain mets, we get 15 gray for big tumors, 24 gray for tiny tumors. Do big tumors need lower dose? I don't think so. I think they need more dose, right? But we do it based on a compromise based on tolerance. But with PULSAR, you can give the higher doses to the bad tumors and give the lower doses to the not bad tumors, and overall have improved tolerance. Now here's an example of immune stimulation. This is a young lady who's got a GBM. She's been through all the treatments. She had had a resection a month or 2 before I met her. And then they, for sort of a last dash effort, they put her on Nevo. They don't use Nevo a whole lot in brain tumors, but let's use 30 and all. And the Nevo didn't work at all. This tumor grew while on Nevo. So Nevo isn't good for this particular tumor. So we decide to do PULSAR. We're going to give, again, up to 5 pulses, but we decided to continue the Nevo because I'd already done those animal experiments. And I what the heck? You know, she's already on it. Continue it. And then completely wipes it out. This is even more interesting. This is a patient with metastatic melanoma who did well. You know, there's a lot of good treatments for melanoma now. He got ipi-nivo and had 2 years progression-free survival, then progressed, and then had a MEK inhibitor. Now it's 3 years total of drug therapy, but now he's in really bad shape. He's resistant to all therapy. He's bedridden. Every bone in his body has a tumor in it. His liver has a miliary tumor. He's got skin mets. So he's in bad shape. He's 300 pounds. He's a full lift just to get him on the table, and he couldn't help us. But, and this is probably the craziest one, I treated one of the biggest liver mets in January. Now, that's not palliative, so you could really criticize me for doing that. And then in late January, I treated a painful spine met with 20 gray pulse. And then he had an ulcerated skin met that was painful. I treated that mid-February. But we continued the Nivo. Nivo is less toxic than ipi, so we figured we'd continue one of the drugs and see if we could get that laboratory effect. And he's 24 months out now, NED, not a single tumor in his body that's visible. And I think it's the combination, because I don't think, obviously radiation couldn't have done that by itself. And the Nivo had already failed, so this is interesting. Of course, that's anecdote. So we're doing clinical trials. This is a case of rectal cancer where we give every month a pulse, because you give 5 gray times 5 for rectal cancer pre-op here. Yeah, that's what we give. So we're escalating the dose and hoping to eventually not do the operation. So this is a hope to become non-operative. So we're escalating up to 40 gray, but with pulses 4 weeks apart. In between, they're getting full fox. I showed this to Ralph Wexelbaum, and he told me it was malpractice, but it's not. But I think that's the first reaction that most people would have doing something like this. In between those PULSAR treatments, the patient's getting a whole lot of assays, repeat biopsies via endoscopy, repeat imaging for radiomics, circulating tumor cells, sequencing of those biopsies to see if the tumor is evolving as time goes by. So collecting lots of biological information, hoping that someday we don't have to give all 5 pulses to everybody, or maybe we abandon it because it doesn't work. So we're mining those functional features coming from the patient themselves, all the different things we do for staging. In the past, especially for medical oncology, biopsies have been the key, right? And I think they'll even become more important with PULSAR. But they still are difficult. It still hurts to get a big needle stuck in your body. And so personally, I think the future of personalization is radiomics. And at some point, we'll be able to image anything, including functional things with imaging. And then it will be non-invasive. So that's, I think, the future. So we're collecting all these features from patients. We're collecting the typical things that we do in a patient, like staging and lab tests and imaging stuff. We call these fundamental features. And there's a lot of them because radiotherapy departments generate a lot of data. We just have tons of data from simulation to treatment. These are things that are commonly acquired. And then there are things that aren't typical. That is, things that might be experimental to collect. So there's a lot of them, imaging-wise, in the blood, etc. So it's all sorts of things that we could collect. Now, the key will be, will we do something with that data that's different from the planned one-size-fits-all class therapy? It's going to cause a lot of angst, especially to lower the dose, right? Like I did in some of those patients. Now, they were horribly incurable patients, so I probably could get away with that. But what if it's a curable patient? Are you going to lower the dose of stage 1 lung cancer? So that's going to cause a lot of angst. And so we'll collect this information, store it in a data lake, collect the outcomes for those, try to create biomarkers from them. But I think we got to look differently at how we do clinical trials. We've done a lot of clinical trials, and they're slow, they're expensive, and often they become irrelevant while you're doing them. And so this concept of a phase 1 through phase 3 trial, there's got to be something better to do. And I think there is. You've heard of these SMART trials. They're a totally new trial design that is becoming increasingly popular. They're used in diabetes now. They're used in psychiatry trials. And what it does is it tries to look for that delta that I was talking about in a more meaningful way. So here's an example of a SMART trial. And in this case, it's another animal experiment that we would do. But so let's start out with a randomization that you can stomach. That is a palatable one that you have equipoise with. So in this case, 10 gray plus 2 drugs versus a bigger dose of radiation plus 1 drug. I could handle that even if that was a human. That makes sense to me. And then you follow the patients based on whether they have a growth delay in this case, so some endpoint. And then you randomize them again. If they had no growth, so it's not working, maybe I continue the same therapy because I just haven't given it enough time. Or maybe I up the dose of radiation plus the 2 drugs. The point is, I'm going to collect a lot of information and get a lot of randomizations from the same patient, such that if I put a number of patients through this, I'll get a matrix of outcomes based on a matrix of treatments. So these are different treatments, different outcomes, all in the same trial. The key to it is time, because like these metrics of endpoints require a meaningful measurement that I can then randomize a second time. So you need time in it. Again, that's good for PULSAR. So in terms of preclinical models, I showed you mouse experiments. Mouse experiments use immortalized tumors. These tumors, if you put a little Coke on the table and then drop these cells on them, they'll probably live on the table for a couple of weeks. They're that aggressive. And so they're not typical of the tumors that we treat in human beings, but that's what we've got right now. But we could treat spontaneous tumors in, I think, dogs and cats, because dogs and cats, it turns out, get tumors. They're naturally occurring. They're much closer to the tumors that humans get if we really wanted to study them. These are the different tumors they get. Now, they don't get any tobacco-related tumors, but they still get a lot of tumors. And it turns out if you're a pet owner, and I was in this situation, if you're a pet owner and your dog gets a cancer, you can go get, they're very specialized. They're just like medical humans. They've got veterinarian radiation oncologists, they got veterinarian surgeons, they got veterinarian medical oncologists. They've got cancer treatment centers with all sorts of support. But the trouble is, and they told me it was a discount because they knew they used some of our SAbR regimens. The guy, the vet that I went to, he wanted $30,000 cash to treat my dog's mast cell tumor. So sadly, what happens then is euthanasia, because most people can't afford that. So I think there's a big need. It could be a win-win. And so we're building in our center, our original center that we had there when I came was 4 bunkers, and it's been abandoned. I'm trying to put some Linux in there and treat dogs and cats. And what I'll do is we'll run those SMART trials on dogs and cats. So this is the wheel of personalization. You start out with all this information, all those features that I described. And there are different types of them, but there's tons of them. And you store them somehow. And then you have an engine that does 2 things. The engine will, number one, validate biomarkers, try to create more biomarkers so that we can get a broader population of patients where we understand what their outcome is likely to be. And then eventually that would supplant the huge data lake into more, focused area. And then the second task is directives. What should we do next? We're in the middle of therapy. What should we do next? Now that's going to be nerve-wracking. So we'll have to have an oversight panel that will agree that the directive, and it might be artificial intelligence that tells you this directive, is a good thing to do or not. If it is a good thing to do, you start treating humans that way. But there's a pretty good chance it won't be comfortable. And so you'll treat companion animals with the exact treatment that that directive said to do. And it'll feed back into this wheel. Or you'll just treat more humans sort of off protocol, like the way I said, until you finally get enough confidence to use the directive. And so sort of what radiation platforms are good for PULSAR, I'll say it's agnostic. It could be anything. PULSAR could be brachytherapy. It could be carbon ion therapy, but most likely it'll be photon therapy. So beyond that, it could be anything. So in conclusion, radiotherapy is an old, somewhat lackluster therapy. We need to reinvent ourselves because we're number 2. Radiotherapy has potential easily to be number 1. So we need to exploit untapped potential. It's time to abandon fractions. 100 years is enough. Use the technology instead to guide beams. Use the technology to guide therapy in terms of the functional outcomes. These benefits of PULSAR are, as I described to you. I'd like to acknowledge a lot of people that helped along this way. Also, I'd like to acknowledge my lab. She's now 15 years old. Brian, I think you saw it earlier.
Dude, I have pictures of this time.
She's now 15 years old. I felt like I should give you some of my views of the world. This is what I see all the time. All right, well, thank you.
Much applause followed and a standing ovation, but let's get to some of the post-lecture discussion.
That's great. By the way, what is the acronym there?
Personalized ultrafractionated, which means not days apart, but months apart. Stereotactic adaptive radiotherapy.
Okay, that's good.
And I didn't come up with that, but I love it. Immunologists came up with that.
Okay. Yeah, no. Well, a term we use here for something that's akin to that, not conceptualized in the same way, is much more prosaic. I mean, we'll sometimes call it dose staged, right? Which is to say, we do this with the gamma knife frequently about large ABMs. You know, give them a few months in between. And it's so true that you give them some time to see this thing getting smaller. And we actually have taken to doing that kind of approach sometimes, give 8 or 10, and 6 or 8, and then maybe 6 at the end to just kind of like taper it off. And you see a functional thing there. So when we analyze this, whatever resident is lucky enough to do it, PULSAR's in the title there, so that's a good thing.
When we started SAbR, we could have done it any way we wanted to, because it was pretty new. And you know, Brian, we did it wrong, I think.
We were, even though it was a departure fractionation wise, we're still sort of constrained.
Yeah.
It's like, you can't do it once a month. I mean, that's not, that would be.
Yeah. But we know that giving a gray in a single fraction will give you at least 3 months of progression-free survival. We know that through randomized trials of metastatic patients on 2 continents. It's just as good as 3010, right? We know that. And now it might recur at 12 months. I think 8 gray in 1 eventually recurs, but it doesn't recur in 3 months. We know that. And so I think we can already do PULSAR per our discretion in high toxicity circumstances. I think people with central lung tumors, with stage 1 central lung tumor, should get PULSAR, because we hurt them with SAbR the way we currently do that at a higher rate than is acceptable. I think that if you're treating somebody with a tumor that needs to shrink and it's, you know, you could consider doing PULSAR. I think that if somebody's already getting immunotherapy and you're going to treat oligoprogressive cancer, why not do PULSAR? Because we're not even sure oligoprogressive cancer should be treated in the first place. But if you're going to do it and they're already on the drug, why not give the pulse right before the drug? It's our discretion. It's not crazy. And then it allows the tissues to heal. I just think it's far more elegant. And then we'll do the trials, though, to figure out the directives, because the beauty of this is that you have an opportunity to personalize the medicine. That will take clinical trials, because I have no idea whether to turn up the gas, how much to turn up the gas, turn down the gas, no idea.
That was interesting, thank you. One of the disease sites that I treat is lymphoma. I was thinking about how there's something that, yeah, boom, boom, exactly.
Yeah.
So we do something similar with much lower doses that
It's the same
a lot of
idea.
people would laugh at, but yeah,
No,
it's
it
the same
is.
idea. Start with boom, boom, and then escalate the dose.
Yeah, it's because
when we need it.
lymphoma doesn't have much of a shoulder. So you don't, lymphoma, germ cell tumors, small round blue cell tumors, they're probably better treated with fractionated radiation, even though I said to abandon fractionation, that was being trying to be thought provoking. But but boom boom's a classic example, because then you can see what happens.
Right,
Because boom boom doesn't always work.
right.
So if you do boom boom and it works, then you could continue that strategy, which is the directive, right?
Yeah.
Because if it doesn't work, then you're going to go to a more conventional treatment. But if it does work, you could continue that strategy. So now you've created a directive based on the biological observation after a boom boom treatment. And quad shot is PULSAR. Have you ever heard of quad shot? We do it. And most of these are based on toxicity, not boom boom. Boom boom's trying to get a sense of how sensitive the tumor is. By the way, I'm not even sure you kill any lymphoma cells with boom boom. It might be some other cells that you're killing. But anyway, the majority of the experience in the past doing this was for toxicity, but there's so much more that you could exploit with the time that you could observe and measure. So
The conversation took a few twists and turns, and somehow it wound up on pizza.
I'll give the example. I love pizza, and I probably eat it too fast. And the cheese has a high heat capacity, right? So it's hot, you put it in your mouth, it burns the crap out of the roof of your mouth. To the point where, have you ever done this where a whole layer of skin falls off after you eat it? Have you ever done that? Yeah. Now, a week later, it's healed, right? But if you did that every day for a week, it probably wouldn't heal. You'd probably end up with a permanent scar on the roof of your mouth. And yet that's how we give SAbR. It was Brian's fault, I think.